Good day everyone. In this presentation, we will examine hypercortisolism as a critical yet often under-recognized contributor to the pathogenesis of type 2 diabetes. Now, using this framework of the Noxious Nine, we will analyze how cortisol excess disrupts metabolic homeostasis that drives insulin resistance, impaired glycemic control, and heightened cardiovascular risk. By the conclusion, it will be evident that identifying and addressing cortisol excess is not simply an endocrine consideration but an essential strategy in comprehensive diabetes management. Now, the pathophysiologic framework for type 2 diabetes was originally conceptualized by Professor Ralph DiFronzo as the triumvirate, highlighting three core defects that includes insulin resistance both in the liver and the skeletal muscles and the progressive beta cell dysfunction. Over time, Professor DiFronzo expanded this model into the ominous octet, incorporating additional mechanisms involving the adipose tissue, incretin system, alpha cell hyperactivity, central nervous system, and renal glucose reabsorption. So let's walk through each of the 8 contributors. The liver produces excess glucose due to insulin resistance and elevated glucagon, while the muscle shows reduced glucose uptake. Now, the beta cells progressively lost their ability to secrete insulin, and adipose tissue increases lipolysis, releasing free fatty acid that worsen resistance and stress in the pancreas. The gut contributes through a diminished incretin effect, and alpha cells secrete excess glucagon, further fueling hepatic glucose output. The kidney sustains hyperglycemia by reabsorbing more glucose, and the brain adds to the problem through neurotransmitter dysfunction and circadian rhythm disruption, promoting central insulin resistance and obesity. Now, an emerging data reveal hypercortisolism as an additional driver intensifying the diabetes metabolic burden. Now, overt hypercortisolism, typically caused by ACTH producing pituitary tumor in Cushing syndrome, presents with clear physical features and leads to long-term health risks, even post-remission. However, subclinical or atypical hypercortisolism without classic cusinoid features can occur in patients with chronic illnesses like type 2 diabetes and hypertension, potentially contributing to their underlying disease mechanism. Now, on your left, we see the classic presentation of Cushing syndrome, first described by Dr. Harvey Cushing in the early 20th century. This image taken from the Johns Hopkins Medical Bulletin in the 1930s illustrates hallmark features such as facial fullness, stria, proximal myopathy, and dorsocervical fat pad, a phenotype that's striking but relatively uncommon today. In contrast, on your right, reflects what we now recognize as the modern presentation of hypercortisolism, often subclinical and far more prevalent. As described by Professor Ralph DiFronzo, this phenotype is defined by the big four: type 2 diabetes, hypertension, obesity, and osteoporosis or fracture. These patients are typically on 2 or 3 oral hypoglycemic agents, sometimes requiring insulin, and often have refractory hypertension despite multiple antihypertensive medication. Now, this shift in presentation underscored the need for heightened clinical suspicion, even in the absence of classic cusinoid features. So let's now look and review the Catalyst trial, which focused on patients with poorly controlled type 2 diabetes. In its first phase, the study enrolled around 1,000 individuals with HbA1c level between 7.5% and 11.5%, despite being on multiple anti-hyperglycemic agents. This includes patients on 3 oral medications or insulin plus another agent, or those with vascular complications while on 2 drugs. Some were also on 2 antidiabetic drugs and 2 antihypertensive agents, yet remain poorly controlled, highlighting a high-risk treatment-resistant population. Among these patients, 24% screened positive for hypercortisolism with post-dexamethasone cortisol level above 1.8 microgram per deciliter. The mean cortisol level was 3.5, suggesting that nearly 1 in 4 of these difficult-to-treat diabetics may have underlying cortisol excess, which could be contributing to their metabolic instability and therapeutic resistance. Importantly, among those who on 3 or more antihypertensive agents, the prevalence of hypercortisolism rose to approximately 33%, underscoring the link between resistant hypertension and cortisol excess. Now, what's the clinical implication? Now, the implication is that hypercortisolism may affect around 1.2 or 1.3 million people with poorly controlled type 2 DM in the US alone. These patients often appear clinically similar to others but require more medications and have more complications. Now, let's us review some key metrics. In the United States, an estimated 40 million people have diabetes, and about 25% of them have an A1C above 8%, indicating poor glycemic control. Among these, roughly 10 million are on 2 to 3 oral hypoglycemic agents with or without insulin, a sign of treatment resistance. Now, from this group, about 5 million American patients meet the criteria used in the Catalyst study, and among them, 25% were found to have hypercortisolism. That translates to approximately 1.1 million Americans living with undiagnosed cortisol excess, which may be contributing to their persistent hyperglycemia and poor treatment response. This highlights the importance of screening for hypercortisolism in patients with difficult-to-control diabetes, especially those on multiple medications with vascular complications. Now, when patients present with hypercortisolism but lack the classic phenotypic features of Cushing syndrome, such as striae, facial fullness, or proximal myopathy, the underlying source is often adrenal in origin. These atypical cases may instead manifest with type 2 diabetes, hypertension, obesity, or osteoporosis, making them easy to overlook in routine clinical practice. A review of causes revealed that in such presentations, adrenal adenomas or hyperplasia are far more common than pituitary or ectopic sources. So identifying the adrenal origin is essential, as targeted intervention, whether surgical or medical, can significantly improve metabolic control and reduce cardiovascular risk. So why screening and detecting cortisol excess is essential in diabetes care? Now, because up to 1 in 4 patients with poorly controlled type 2 diabetes may have undiagnosed cortisol excess. These individuals often do not show classic cusinoid features, making the condition easy to miss. Yet cortisol plays a powerful role. It drives insulin-resistant hypertension and significantly increased cardiovascular risk. So who should be screened? Now, focus on patients with A1C above 8% despite being on 2 or more oral agents, with or without insulin. Also include those with refractory hypertension on multiple medication, vascular complication, or obesity with poor therapeutic response. These are the patients most likely to benefit from early detection and targeted intervention. Then, the next question is how to screen. The recommendation method is the 1 mg overnight dexamethasone suppression test, or the DST. A post-DST cortisol level above 1.8 microgram per deciliter indicates inadequate suppression, suggesting possible hypercortisolism. To confirm proper medication intake and absorption, a serum dexamethasone level should exceed 140 nanogram per ml, and a cortisol level of 3.5 microgram per deciliter or higher is considered a strongly positive result. Now, the purpose and mechanism of suppression test. Now, dexamethasone suppression test is a simple yet powerful tool used to evaluate whether the body's cortisol production properly shut down in response to oral dexamethasone as synthetic steroids. Again, the protocol involves administering 1 milligram of dexamethasone at 11 p.m. followed by a blood cortisol measurement at 8 a.m. in the next day. In a normal physiological response, cortisol levels should be suppressed below 1.8 microgram per deciliter. If cortisol remains elevated above 1.8, it indicates autonomous cortisol production, which is a hallmark of subclinical or overt hypercortisolism. Now, cortisol naturally follows a circadian rhythm, peaking in the early morning, measuring at 8 a.m., captured the expected suppression window after overnight dexamethasone, ensuring standardization and diagnostic accuracy across all patients. Now, besides the 1 milligram dexamethasone suppression test, other tests may be used but have some limitations. For example, urinary free cortisol is often normal in subclinical cases. Late-night salivary cortisol suffer from poor specificity and can be cumbersome in practice. Supportive markers include low or low normal ACTH, which help exclude pituitary or ectopic Cushing syndrome, and a low DHEA, which further supports an adrenal source. These results help clinicians recognize autonomous cortisol secretion, commonly linked to adrenal adenomas, especially in patients with refractory metabolic condition. Now, imaging studies are essential for localizing the cortisol-producing tumor once biochemical evidence is established. Now, here is a flowchart guide for clinicians through a stepwise evaluation of suspected cortisol-producing tumors, starting from clinical suspicion to hormonal testing and imaging decision. Start by confirming cortisol excess using dexamethasone suppression test. You can use urinary free cortisol if done, or late-night salivary cortisol. If confirmed, check plasma ACTH, and a low ACTH suggests an adrenal source. Proceed with adrenal CT. Elevated ACTH points to a pituitary or ectopic source, and you start with pituitary MRI. If MRI is negative, consider whole body imaging to locate ectopic ACTH secretion. Now that we have walked through how to evaluate suspected cortisol-producing tumors, from clinical suspicion to hormonal testing and imaging, let's look at why these matter. In a cohort of 628 patients, those with cortisol-producing adrenal adenomas shows markedly higher rates of cardiometabolic disease compared to those with non-functioning adrenal adenomas. The prevalence of type 2 diabetes was nearly 3 times higher, 19% versus 7%. Metabolic syndrome was present in 43% of cortisol-producing cases compared to just 12.7% in non-functioning adenomas. Cardiovascular events were also more frequent. Myocardial infarction occurred in 6.4% of cortisol-producing cases versus 1.5%, and stroke was reported in 5.1%, again compared to 1.5%. Now, these findings underscore the clinical impact of autonomous cortisol production, even in the absence of classic cusinoid features. So, early detection and targeted management may reduce long-term metabolic and vascular risk. Now, this survival data shows that treating comorbidities without addressing cortisol excess is not enough. Patients managed only with medication for diabetes or hypertension had significantly lower survival compared to those who underwent surgical removal of cortisol-producing source. The red curve, no surgery, just drug treatment, versus blue or green curve with surgery. Now, to improve long-term outcome, it is essential to actively search for any tumor or lesion causing elevated cortisol level, whether adrenal, pituitary, or ectopic, and attempt to remove the underlying cause. Without this, hypercortisolism continues to drive cardiovascular risk and mortality. Now, although endogenous Cushing syndrome is rare in the general population, affecting just 0.7 to 2.4 per million, its prevalence rate rises to 2 to 5% in patients with hypertension and diabetes. Hypertension is present in 80% to as much as 85% of individuals with Cushing syndrome, making it the second most common clinical feature after weight gain and obesity. Both systolic and diastolic blood pressures are elevated in parallel, and the conditions affect males and females equally. Interestingly, blood pressure levels do not correlate with plasma cortisol concentration, highlighting the complexity of cortisol impact on vascular tone and sodium retention. Now, treatment depends on the underlying cause of cortisol excess. Management begins with pharmacologic control of comorbidities such as hypertension, hyperglycemia, and dyslipidemia. Now, this is to stabilize the patient's metabolic profile. If cortisol excess persists, glucocorticoid receptor antagonists may be used. Mifepristone, approved by the US FDA as a repurposed drug, this drug began as a progesterone blocker for pregnancy termination. Now it's repurposed in the Catalyst trial for resistant type 2 diabetes that improved glycemic control but may have caused hypokalemia, hypertension, edema, vaginal bleeding, and QT prolongation. Relacorilant is under clinical investigation. To reduce cortisol synthesis, adrenal steroidogenesis inhibitors are used, but some of these are off-label. This includes ketoconazole and levoketoconazole and others. For patients with adrenal adenoma, surgical removal may be curative. If the source is pituitary or ectopic ACTH secretion, targeted tumor resection is required. So once we have addressed the underlying cause of cortisol excess, whether through medication, surgery, or receptor blockade, we return to the bigger picture on how cortisol fits into the pathophysiology of type 2 diabetes. Originally, the ominous octet described 8 core defects, but with growing evidence from trials like Catalyst, we now recognize a 9th player, hypercortisolism, as a hidden driver of insulin resistance, beta cell stress, and metabolic dysfunction. This expanded model, the Noxious Nine, helped us connect endocrine disruption to the broader landscape of diabetes care. So in summary, hypercortisolism is often missed, especially in patients with Big 4, refractory hyperglycemia, resistant hypertension, recent weight gain, and fractures. Screening with the 1 mg dexamethasone suppression test is the key. Excess cortisol disrupts insulin secretion, hepatic glucose output, lipolysis, and glucose uptake. The ominous octet described 8 core defects in diabetes, but evidence now adds hypercortisolism as the 9th, transforming the octet into a Noxious 9. Recognition shift the perspective on hard to control diabetes towards an endocrine basis, with early diagnosis improving prognosis. And on that note, I will conclude this presentation. Thank you for listening.